Okay, wonderful. Well, we are steadily approaching the last hour of our Digital Health Symposium, and it's my pleasure to introduce our next panelist, Dr. Ami Bhatt, Chief Innovation Officer of the American College of Cardiology. Ami, are you there?
Yes, thanks so much for having me.
No, wonderful. Pleasure to have you on. I know we are running a little bit late, but we will do a full 10-minute interview with you around what you folks are doing right now at the ACC. But for the folks that don't know you in the audience, please give us a bit of background about yourself.
Yeah, absolutely. So, this has actually been a great day and a great discussion and so much that's relevant. So even though I'll talk about cardiology, I think it's just important to recognize that it's really applicable to all of us who are looking into digital health. So a cardiologist, I was the director of outpatient cardiology and telecardiology at Mass General Hospital prior to now being the chief innovation officer at the American College of Cardiology. Quick background, I started telemedicine in 2013. I took care of largely young adults with heart disease, and these were people who were at school or had young families, often lived far away from Boston, and wanted to be more digitally forward in how they interacted with me. So in a way, it's my patients who helped drive me to start telemedicine, think about digital stethoscopes, handheld ultrasound, blood pressure cuffs in the community, all the things that we do now. For 7 years, nobody really got on board. It was hard because we didn't have workflow and we didn't have systems and we didn't have the same language. And then unfortunately, COVID happened. But fortunately, we did actually know a little bit about how to deliver virtual care. And I think that really helped us over the past 3 years. So that's kind of how I ended up here and now focused on how can we really provide high quality cardiovascular care in the communities where people live, because that's what we need to do. And we need to do that equally for everybody. And so most of my time is spent looking at companies, whether it's digital health companies, or investment companies or larger companies who are coming into healthcare and have the infrastructure to reach deep into communities, within 10 miles of where everyone lives, and bring them all together and say, how are we going to convene ourselves to be successful at really covering that last mile as the last discussants were talking about?
No, absolutely. Thank you, Ami, for giving us that rich background that led you to becoming the CIO of the American College of Cardiology and stuff. It'd be great to hear about the different kinds of innovations like you spoke about with COVID kind of giving us that silver lining almost of really progressing with the way that tech is coming into a lot of the traditional ways of administering care and, especially in that final mile. What is it like, if you can go into some detail about some of the innovations that you've been working on and maybe some of the challenges that you've faced
absolutely.
in recent years?
So, the way we think about it is we have to think about it holistically. And so first of all, we really do promote blended care. And so at no point are we saying something virtual or digital replaces in person, but now we have an armamentarium that includes things that allow care at a distance. And I think that's really important. We also think about it as moving from episodic to continuous care. What we've been doing is, as cardiologists, we'll see people once a year, twice a year, 4 times a year, but it's really episodic care. And our goal is to be able to monitor people in the communities where they live, understand how to help monitor chronic disease kind of as a baseline of that pyramid, then thinking about how do we catch the rising risk patients? What we really want to know in the community is sick from not sick. Who needs more attention right now? Who is okay waiting? That's both good for resource utilization and optimization, but it's also good for us as patients to know, I'm not as sick as I thought. The health-related anxiety we've seen in COVID has been significant. And so all of the technologies we look at really help us think about how do we address this. And so, one set is telemedicine, really looking at virtual care platforms. And one thing that's interesting is we recognize that we can't have care platforms separate from bioperipherals, which are going to measure your heart rate, your blood pressure, your temperature. And each of those have their own dashboard, separate from care at home services that are going into the community. Now, it's not easy to pull all these 3 together at once, but it's actually really important to think about creating an environment where the digital health that we're using, whether a wearable, medical grade, prescribed device in the home or in the community, what is that plugging into? How are people seeing that information? Is the patient being left just without knowing what to do? Or is there some clinical backing to that to help them understand how to process? And so we spend a lot of time working on remote patient monitoring, care at home services. So Dispatch Health is kind of just one example of a brilliant care at home service where the innovation is really going back to the way we used to do things, going back to home visits, but recognizing, hey, this is the next urgent patient. Let's make sure we get there in this order with the right things. Let's communicate back to the clinicians. And then thinking about all the data we get from partnering with a digital stethoscope or a handheld ultrasound or a remote patient monitoring system. What are we doing with that data? How do we process it? And we have to recognize that the human brain, and especially kind of the average clinical team right now who's very burnt out and really trying to keep up with the volume of patients, the volume of multiple chronic illnesses, and the volume of knowledge we have, we need to help them. And we need to help them by taking all of that data and starting to process it. So you have the right data at the right time with the right clinician-patient interaction. And so a lot of the work we're doing now is looking into what we like to call collaborative intelligence rather than artificial intelligence, because there's nothing artificial about it. It's something we're working on. We know the data we need help processing it, and we need to iterate on the output we get if it doesn't seem exactly right till we get it right. So spending a lot of time with AI companies and thinking about algorithms and how we're processing the data and doing it in a way that's really based in knowledge and clinical knowledge so that we can elevate the foundation of care in the community.
No, that's really wonderful to give us that kind of overall and also detailed level of the way you're now looking at administering care within the community, and also the priority of care as well, which I think often gets overlooked. Digital health always is perceived as what the technology is, and what we can leverage from that. But there is also obviously that human aspect of who needs the care the most, and to prioritize that way. So that's a really excellent way of giving us some perspective on that.
No, absolutely. And I love that you think about, you're kind of triggering this concept of equity as well, right? And it's probably important to address up front. Cardiovascular disease has lots of inequities globally and here in the United States. And so it's really important for us to recognize that if we're using digital health and we're using blended care in cardiology, that we are doing it in an equitable way. Actually, yesterday, I was presenting at Biomed Device Boston, excellent conference, still ongoing today. And they're actually met a company that is able to take a chip, they call it note card, and that chip, if in your device, can actually give you cellular connectivity. And so those are also the kind of things we're looking for, is how can we really get into the community and partner either with technology that can help us link, devices or individuals to more data, to their clinician, or how can we partner? So I'll tell you one more kind of fun story, because yesterday the White House had a meeting on hunger and nutrition. And there, two of our partners were there. One is called HIGI, H-I-G-I, and the other is called Food Smart. And these two really work on getting into the community. The HIGI station is a place where you can actually get what is like a physical exam that is monitored for blood pressure, heart rate, et cetera. Food Smart is a company that does food as prescription medicine. We as physicians can actually prescribe medicine, food as medicine for our patient that is then linked to their food stamps or their SNAP program. And so that way they can actually be able to both know what food to get, afford that food, and know that they can afford it by linking it. And then there's actually been some very kind groups who actually do food delivery services in certain areas who are then able to deliver that food to the home. So again, innovation for the American College of Cardiology, although we're really thinking about the digital transformation of healthcare, we recognize that there's so many ideas that are so important, and including the community in it is really the only way for us to move forward. So.
No, that's some really, really wonderful insights there, Ami. Thank you so much. I wish we had more time to go over more examples and stuff.
I know, and I'm sorry I can't be there at 2 p.m. today, but hopefully in a future day we can chat some more.
No, absolutely. Well, I appreciate you coming on anyway, just to share your insights at this time. I know you're traveling, and yeah, I'm so thankful that you took 10 minutes out your day to come and speak with the audience today and share your insights from the American College of Cardiology perspective.
Great. Thank you so much.
Thanks so much, Ami. Okay, wonderful conversation there with Ami, and really looking at the way that we use digital health, not just in the last mile, but also to cover those disparities in the community as well. So into the last hour of the Digital Health Symposium now. Before we move on to the next panel, very quickly, I just want to inform everybody that the Breakthrough Alliance has a individual membership that allows folks like yourselves that are watching the webinar today to be able to leverage HITLAB and the Breakthrough Alliance's connectivity and educational offerings as well. We have various different tiers that allow you various levels of connectivity and access into the HITLAB network and education system. So please feel free to check that out. Ansley and I should be putting some information in the chat box. And a reminder just to join us again after the symposium is over for some further connection and a workshop for startups by Moses and Singer as well. And we have another book giveaway just before we go on to Bill. So we're going to take 30 seconds here very quickly. Fingers on keyboards or keypads as we go into another book giveaway for Lorraine Marchand's The Innovation Mindset. I believe it's the last one today. So I'm going to go on to the question now. So who coined the phrase, quote, evidence-based design, end quote? Is it A, James Beasley, B, Harrison Meader, C, Roger Ulrich, or D, David Smith? We are going to give everybody 10 more seconds before we reveal the answer. And I think we have our winner already. The answer is C, Roger Ulrich. And I believe Rich Carpenter, you were the first to answer. So Ansley will be getting in touch with you to sort out getting you a copy of Lorraine Marchand's book.